Bismillahirrahmanirrahim. This is my honor to speak some word on asthma in front of my great teachers, Professor Salatullah Khan, Professor Shif Jamal, Professor Khalid Waeed, and Professor East Muhammad, who was principal of Garden Medical College at that time. My lecture will be, inshallah, very precise and short. What we know about asthma, bronchial asthma is actually dysregulation of respiratory epithelium. And you can see there are different agents or noxious agents which induce changes in our airways. And these noxious agents in turn dysregulate the function of macrophages and dendritic cell, and these cells in turn induce the inflammation in our airways. So this is the main pathophysiology of asthma, that as a result of exposure to antigens, serum Ig is created, and this serum Ig bind with our mast cell or eosinophils, and in turn it induces degranulation or bursting of these cells, and as a result bronchoconstriction or constriction of airways. So if you want to treat asthma, either you should remove the antigen or you should destroy the serum IgE, or the third step is you should stop the binding of this IgE with these mast cell or eosinophils. So first step is to remove antigen. Second step is to destroy IgE by using anti-IgE monoclonal antibodies. And the third step is inhaled steroids. Inhaled steroids stop the binding of IgE with these cells. This is the mainstay of treatment in bronchial asthma. But current days, we noticed a change in our environment, that is smoke. And as a result of smoke and exposure to noxious agents in our environment, we are developing a new type of asthma, which is not IgE-mediated asthma. And this asthma due to exposure to noxious agent, as I have mentioned, as a result of TSLP, our airways are producing more and more smooth muscle cell or hypertrophy of smooth muscle cell. So this asthma is little bit different from IgE-mediated eosinophilic asthma. And as a result of exposure to these noxious agents in asthma, we can see changes in our airways. There is hypertrophy of smooth muscle cell, narrowing of air lumen or lumen of our airways, and irregular surface of our airways. There is some existing evidence that in addition to use inhaled steroid, you must add LAMA, long-acting anti-muscarinic agents, for those patients who are not being improved by inhaled steroids and long-acting beta agonists. This is the stepwise management approach of bronchial asthma, and I believe only in one track of management of asthma, because you will confuse if you study track 1 and track 2. In this stepwise approach, you can see step 1, step 2, and step 3. These are basically managed by inhaled steroids. You are increasing stepwise dose of inhaled steroids. So there is no role of triple therapy up to this level. But in step 4 and particularly in step 5, if patient is symptoms are not relieved by using inhaled steroids, adding leukotriene receptor antagonist and other bronchodilator, you may add in this patient LAMA or triple therapy, which is combination of LABA, inhaled steroid, and LAMA long-acting muscarinic agents. I am again repeating, please do not start patient of this triple therapy. Mainstay of treatment is inhaled steroid in management of asthma. But those patients who are not responding to inhaled steroid, we may benefit, or those patients may get benefit by adding LAMA. So how to give inhaled steroid or inhaled LAMA? We must use inhaler, but every inhaler is not as effective as inhaler of good company. Reason behind this, size of the particle which is released in when we use inhaler, the size of the particle in some inhaler is not adequately small. You can see in this picture, if the size of the inhaler is 1.5 micron, you have best penetration in small airways. But on the other side, if the size of the particle is 6 micron, this is only very small deposition of drug in the airways. So using inhaler with poor quality is useless for the patient. Next, how to use inhaler?
Any difference at all?
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
So she is using inhaler in this way. So this is important to teach how to use inhaler. This is brief view, how to use inhaler.
Small volume spaces generally require no assembly. Remove the cap and shake the inhaler well, then place it into the spacer. Breathe out fully before the dose is inhaled. This will help the full dose of medicine to go into your lungs. Keep your head upright and lift your chin slightly. If your chin is tilted down, the medicine will enter your mouth and throat rather than your lungs. Tilting your chin slightly upward will also help to open up your airways. Place the spacer mouthpiece between your teeth and close your lips around it. This creates a good seal with the lips so that the medicine doesn't escape. If you have difficulties coordinating your breathing, you can breathe through the spacer to get into a regular rhythm. This makes the timing of the in-breath after pressing the canister less critical. Continue your normal breathing through the spacer after you've activated the inhaler to make sure you get your correct.
I think sufficient. Thank you very much before you go to sleep.